Good morning. Apologies for the short delay. Today, Dr. Reba, our Assistant Professor in Medicine 2 and Clinical Epi, she'll be taking a slightly different study design from what we have done earlier, an observational study looking at before and after an intervention. It's interesting, something new for us to learn, and we hope you enjoy her teaching. Over to Reba.
Thank you, sir. So today we'll be looking at the critical appraisal of a quasi-experimental study using pre versus post-implementation design. So we're in the hospital monthly death audit meeting. The MSS, despite improvements in the ICU care and sepsis management, our hospital mortality has not improved much. So the ICU team state their observation that many patients are being shifted too late to the ICU. So because we're recognizing the deterioration of patients in the ward too late, the window for intervention is very narrow. The surgery team they say that though they do strict morning and night rounds, but during the day, because they're scrubbed up in theatre all the time, patients can deteriorate during that time. And by the time they pick up, it's already evening. And medicine team has its own problems. Their OPD starts at 8, ends at 7 p.m. Although they have an on-call team on the floor, it is very difficult to predict which patient is going to worsen when there are 40 patients in a ward. So after a brainstorming session, they come up with some questions. So how can we identify sick patients earlier? And can we use already available data in the electronic health record to predict which patients are likely to deteriorate? And how can we act upon the predictions to intervene faster? So today we'll be looking at this article. It's called Implementation of an AI-Triggered Rapid Response, the Association with Mortality. It was published in the NEJM in August 26th. So if you look at previous observation studies, patients often show signs of clinical deterioration 24 hours prior to a serious clinical event which requires an intervention. So because we delay in the treatment of these sick patients, it will result in increased ICU admissions, increased length of hospital stay, increased cardiac arrest, there can also be increased death. Now one way to circumvent this is early warning systems. So early warning systems, these are solutions to address suboptimal ward-based care. And what is the use? They help us to identify patients earlier, refer them appropriately, and respond faster. Now if you look at early warning systems, they basically assign numeric value to several physiological parameters like the patient's blood pressure, heart rate, oxygen status, and then they derive a composite score, and some of the physiological elements are given different weights based on the level of abnormality. Now we're all aware of the traditional warning systems. We had used this during the COVID time, the new scoring system by the NIH. It's called National Early Warning Score. We have a modification called the Modified Early Warning Score. Recently, they have machine learning systems also which can predict the patient's deterioration. Now, as opposed to the traditional early warning system like the new score, they're very static. So they only detect instability after the instability has already occurred. But on the other hand, the newer machine learning algorithms, they use real-time data and it's dynamic. So even before the patient can actually deteriorate overtly, they're able to identify high-risk patients. This is just an example of one of the models. It's called the ECART-5. You can see how they have modeled and they've given different weightage to different physiological parameters. Now, one such newer machine learning early warning system is called the EPIC System Deterioration Index. So EPIC is a electronic health record a system which is used by a lot of countries, especially Canada and US, and even some hospitals in India using. They have developed a deterioration index score. It's a proprietary machine learning early warning tool within the EPIC's cognitive computing suite. So it basically calculates a patient's risk score from 0 to 100 every 15 minutes using fresh electronic health record data, and it stratifies the patients. If the patient score is more than 60, an alert pops up saying this is a high-risk patient. Now, if you actually look at what they have taken to make this model, they had 31 parameters. So on the left, these are parameters, the patient's vital signs, like the blood pressure, heart rate, respiratory rate, saturation, etc. Here you have all the lab parameters, the WBC, the creatinine, the blood pH, and the anion gap. And these are some things which they need to get from the nursing health record, like the GCS of the patient. For example, respiratory effort assessment. If the nurse writes the patient has labored breathing, they'll be given a higher score. And the only demographic factor which is taken into account is the age of the patient. and it has nothing to do with the comorbidities or other physiological problems. Now, if you look at all the previous research, there are many other models which have been developed, like the chart watch. I had shown you the ECART picture and the truth prediction models, but none of them really translated to clinical effectiveness. Why? Because the problem was all these models, they relied on a clinician to escalate and to respond. So finally, at the end of it, even though the clinician got an alert, it was up to the clinician to decide whether to act or not to act. So what if someone actually acts on every prediction? Okay, so you have to link that AI deterioration model to a standardized automated escalation pathway. So this particular study, what they have done is they have taken patient data from the electronic health record. Then the system calculates a deterioration risk. Once the EDI score reaches more than 60, a high alert gets popped up, and immediately the rapid response team gets notified, and the rapid response team will come and assess the patient, and then they will decide on the clinical intervention. If you link the AI model with the rapid response team, is there a reduction in mortality? So that was the premise of this particular study. Now, if you look at the intervention categories, you can classify them as 7 P's. You can have pills, you can have programs, practices, principles, products, policies, and procedures. If you look at this particular intervention, you would probably put them under practices. Examples of pills would be SGLT2 inhibitors. Examples of a program would be pulmonary rehabilitation program for COPD. If you look at practice, the hospital practices early mobilization of all ICU patients. If you look at an example of a principle, shared decision making between clinician and patient. If you look at examples of products like continuous glucose monitor for diabetes, if you look at policies, maybe hospital antimicrobial stewardship policy. And if you look at procedures, it's a set written instructions, like for example, how would you manage sepsis? So if you look at this particular intervention, it would probably come under policies or programs. Now, if you look at the traditional translation pipeline, before an intervention works, we have a pre-intervention period where you do some bench work to see if the program could work. Once you've developed the program, you need to see whether the program actually is efficacious or not. Efficacious studies are basically done in a very ideal setting. It's a very tightly controlled setting done by a highly trained research personnel to ensure high fidelity. And once they say that the program is actually efficacious, then you move on to the effectiveness studies. So effectiveness studies are done in real world. They're more of pragmatic studies. And here you will have a heterogeneous patient population to see whether the intervention is actually effective or not. And once you have established the efficacy and effectiveness of an intervention, then you go on to the implementation. That is, you make a program work. Now, whenever you do efficacy or effectiveness trials, we must always use random assignment to account for unmeasured confounding factors. Now, implementation research, on the other hand, often has trade-offs between a randomized trial as well as an observational design. It's not always possible for us to do a randomized trial when we're actually looking at implementation designs. Because randomized control trials have high internal validity, but it's very difficult to mount it. But observational interventions, although they have very little experimental control, they still provide valuable information. Now, if you look at our strategy, however, if you wanted to develop a study, there are 3 ways that you can do it. You can either develop a within site design, you can do a between site design, or you can do within and between site comparison designs. So I'll explain what each are. So within site design, it's called a quasi-experimental study. Common examples are post-design studies and pre and post-design studies. Now, if you look at what a post-design study is, you start a study, you immediately implement the intervention, and then you look at the outcome alone. You have nothing to compare it baseline. When can you do these kind of studies? When it's impossible for you to, when you don't have a new intervention yet, for the first time you're bringing it out. For example, during the COVID pandemic, when the government brought in lockdowns, that time we do not know how many cases were there pre-lockdown and post-lockdown, because RT-PCR testing was not widely available. So that time you don't know what were the baseline COVID cases. After you've locked down, then when the PCR test came, you actually knew how many COVID cases you had the post-lockdown. You can only compare this with published results or standard metrics. You don't have any baseline data for comparison. But on the other hand, if you look at pre and post designs, you start the study, you already measure your outcome of interest, then you do the implement the intervention, and then you collect data on the outcome. So this is called pre and post design. So you have pre-intervention data available for comparison. Now our study actually uses the pre and post design. Now if you look at better studies, you would say that as experimental studies, which are called between site designs. Suppose you have only one new intervention, you can compare the new intervention strategy with the usual practice. Or if you have two new interventions, you can actually do a head-to-head randomized implementation trial, where you give one patient, one set of people strategy 1 and another set of people strategy 2. Now suppose you have 2 or more interventions and each of those interventions have levels to them, you can do something called a factorial design for implementation. Then you can have 2 into 2 tables or 3 into 3 tables. Now just an example of that. So this was a study where they had looked at hazardous alcohol use patients who come to emergency department. And they wanted to compare 2 steps of intervention. One is they would screen the patient using 3 different kinds of tools, and they would also intervene. They would do a minimal intervention like giving a patient an information leaflet, or they can briefly advise the patient, or they can have a counselor in the emergency department who would give a brief lifestyle counseling. And they wanted to see which of these strategies are the best. To use the fast screening tools and give the patient information leaflet, or using the fast screening tool and giving brief advice, or using the fast screening tool and giving brief lifestyle counseling. Or should you administer the PAT test first and give the various intervention. And the third part is whether to give SAS-Q intervention and give the various interventions. So if you actually see, there are 3 levels to both the interventions, and you end up with almost 9 interventions. Now, this is another kind of a between site trial design. Just looking at it, can you guess what methodology this is? So this is called a SMART design. It's called sequential multiple assignment randomized trial design. So here what you can see is you randomize into intervention A, intervention B. If they're responding, you go ahead with intervention A. If they're not responding, you re-randomize them into intervention A plus B and intervention C. And same thing in intervention B. So here you can see that there are multiple treatment options. You have treatment option A, you have treatment option B, you have treatment option C. You also have a treatment option A plus B, and you have decision stages. For example, if they don't respond, you need to make a decision to randomize them further. You also have a tailoring variable which you use to decide whether a patient is responding or not responding, and you also have decision rules. Now, sometimes it's not ethical to prevent your control group from not getting intervention. For example, if you're introducing alcohol rubs into a hospital, it's not fair that you give alcohol rubs to some wards and withhold it from other wards. So in this case, what you can do is use crossover designs. That is, a particular ward gets an intervention, then after some time, a second ward can get the new intervention, and after a period of time, the third ward can get a new intervention. The important thing to notice is the timing of the way the different wards start off an implementation strategy is randomly assigned. So there are 2 kinds of crossover designs. One is called the wedge, complete wedge. One is called the incomplete wedge. Now when you talk about complete wedge, here is your study, the start of your study. So if you look at site 1, at the end of 3rd month, they get the new intervention. If you look at site 2, at the end of the 4th month, they get the new intervention. And if you look at site 3, at the end of 5th month, they get a new intervention. Now, all the baseline data is collected for all the different sites at the start of the trial itself. And when for the patients in site 1, when they are on the intervention phase, they actually control it with the control will be the pre-intervention phase of site 4. Now, what is the difference between that and an incomplete wedge? Sometimes you have financial constraints and you cannot be collecting data for site 3 and 4 when your intervention is very late. So in that case, what you do is just before you roll out the intervention, 3 months before you start collecting data, and 3 months later you collect data for the site. So that's called an incomplete wedge design. Now coming back to our study, what they have done is a pre versus post implementation design. Now to critically appraise it, there are not many tools available. I found one tool by the NIH. It's called Quality Assessment Tool for Before and After Studies with no control group. It's a simple checklist which we'll go through. So first, let's look at the study objective. So the objective of the study was to assess the reduction in risk-adjusted inpatient mortality following a novel implementation strategy in a large regional health system. And what was the implementation strategy? You link the epic deterioration index with an automated response team activation. Now this is the PICOT statement. So the population were all adult medical and surgical admissions with a deterioration index greater than or equal to 60 at any time during the hospitalization.
Recording stopped.
And the population was recruited from October 1st, 2022 to August 30th, 2024. And if you look at what the implementation strategy was, it was a real-time targeted electronic health record alert with an RRT push notification. The control was care as usual. The outcome was risk-adjusted hospital mortality, and the time was during the hospital stay. So the ideal method to have done this is you randomly allocate 2 hospitals or 2 wards. One of them would be the treatment group, one would be the control group. You measure the mortality before the intervention. You start the intervention, then measure the mortality and compare between both the groups. This would be the ideal method. But what they did was a cohort study. They did a staggered cohort study using the pre versus post implementation design. For example, hospital A was recruited. You would give an intervention. They will have a pre-intervention period and a post-intervention period. So the control for the post-intervention would be the pre-intervention patients. Now hospital B was recruited in a different timeline, maybe after 2 or 3 months. So when so the control, so the pre-treatment group for the hospital B would simultaneously act as a control to the post-intervention group in hospital A. So if you look at the inclusion criteria, so they had consecutive cohorts of all adults admitted to an IP unit between October 1st, 2022 and August 30th, 2024. And their inclusion was EDI score should be greater than or equal to 60 at any time during the hospitalization. Now the setting, it was done in New Jersey, USA. The health system that they have used was the largest health system available there. It's called Robert Wood Johnson Barnabas Health System. So overall, all the hospitals had an inpatient capacity of 4,756 beds. They had about 3.6 lakhs annual admissions, IP admissions. Now they have taken 11 hospitals from this chain. They've taken 2 large academic centers, 6 community teaching centers, and they have also taken 3 non-teaching community medical centers. And they have all used the EPIC electronic health record, and the version of the deterioration index was version 1. So was the study question or objective clearly stated? Yes. They have clearly defined the eligibility and selection criteria, and the participants were representative of all those who would be eligible for the intervention in the general or clinical population, because they have recruited every single patient who came to the hospital. And were all eligible participants, did they meet the pre-specified entry criteria? Yes. The 5th question, was the sample size sufficiently large enough to provide confidence in the findings? So they have not told us about the sample size. But on back calculating, it was adequate. That is one flaw in the study. Now let's move on to the intervention that they had. So the first step was calculating the EPIC deterioration index. So every 15 minutes, the system would calculate from the electronic health record data a score. And this column was added to the patient list, displaying the current score and the corresponding color. I will show you the picture in the next slide. Then they would have an electronic health record alert. When the score is more than 60, immediately there will be a red banner for that patient. If the score is between 30 to 59, one yellow alert would come. And this alert will stay on for 48 hours. Then the third important step was they had an automated RRT notification. The minute the EDI score turned more than 60, immediately a message would be sent to the rapid response team, and they had a unified communication group in the mobile device. So they did not rely on clinician to notice the rapid response team. And the next thing is they had a standardized RRT response. So all the people involved in the RRT had to immediately come in and assess the patient, and they were given education before this study was rolled out. And another interesting thing is they had something called alert fatigue safeguards. So to prevent unnecessary alerts for patients who are already in ICU level care, patients who had comfort care, this was suppressed. And patient who already had an RRT response within the past 6 hours or had an EDI red alert for the past 48 hours were also, the notification was suppressed. So this is how it looks. This is their IP list. You have the patient names over here. You have their admission diagnosis, who were the doctors, the code status, are they DNR patients or do they need full treatment, how many days of hospital stay they are in, and this is the column. They have the deterioration index score. They will have the score and the color coding also. And suppose you hover over here, you have another pop-up will open up, which tells you that patient's EDI trend over the past 24 hours, and also tells you which parameters are contributing to the high EDI score. And so each patient would get a storyboard alert also, and this is the message which goes to the rapid response team. So they will get the patient name, and they will also get what the EDI score was. So the rapid response team, it varied across the hospitals. So 10 out of the 11 hospitals had 24/7 coverage. One hospital did not have a rapid response team in the night time. And one hospital did not actually sign into the unified communication group. All the rapid response team had a licensed doctor. 6 of them had dedicated RRT nurses. And before the program was rolled out, they had a comprehensive frontline provider education program. So because of the fact that one hospital did not have 24/7 coverage and one hospital did not have a unified communication group, some push notifications did not lead to a rapid response team activation. Now what are the outcomes they looked at? 2 important outcomes. One is the in-hospital mortality. Other one was escalation of care. That is, if a patient was moved from one level of care to a higher level of care. So this is all the data that they collected. All the data came from the electronic health record itself. They've taken patient characteristics, they have taken the EDI variables. Intervention was when the first automated RRT push notification occurred, and the outcomes were in-hospital mortality and escalation of care. So was the test intervention clearly described and delivered consistently across the study population? Here I said no, because one of the sites did not have a 24/7 coverage. Next thing is whether outcome measures pre-specified, clearly defined, valid, reliable, assessed consistently across all study participants? Yes. Third thing is whether people assessing the outcomes blinded to the participants' exposure interventions. They did not blind it, but it would not make a difference because they're looking at an objective outcome of mortality. The next thing is this study did not really have a pre-specified study protocol, was not there in the supplementary table. So it's very important that before the data arrives, before we look at the results, we should already have a statistical test in place. We must not change it after we look at the data. Now, if you look at the population, the pre-intervention patients were 10,803. Post-intervention number were 12,329 patients who had an EDI score more than 60. As I mentioned before, they did not have an a priori sample size calculation. So the analysis was fully done in our software version 4.4.2. Now, let's look at what the primary analysis was. So the primary analysis was a multivariable regression to see if the odds of a patient for mortality improved after giving the intervention. So the variables that they have taken into account for the multivariable regression were age, sex, race, ethnicity, the comorbidity score, the EDI score, that is the deterioration index score, the hospital type, as well as the season. The intervention was basically whether the patient got an RRT push or not. So that would be a hospital-specific time-dependent variable. Another thing they've taken is they've taken hospital clustering. Random intercept was used. So basically what they're saying is, because they've done a cluster study, right, many different hospitals have been used, they have allowed each of the hospital to have its own mortality. So they have not chosen a fixed effects model saying that all hospitals have the same mortality and respond the same. And they've also done a Spearman's correlation coefficient, which tested for multicollinearity. Okay, so I'll ask you a question. Just because after the intervention, the mortality improved from before to after, can we say the strategy is really working? So that's an important concept called the secular time trends. What if the mortality was already falling before you had introduced the intervention? Then what will happen is you will say that the intervention has caused the drop in mortality. Okay, so this is called a secular time trends. So one way to actually account for the secular time trends is to do something called an interrupted time analysis. So you will have a pre-intervention phase, you will have an intervention period, and you'll also have a post-intervention period. So if you look at the trend in the pre-intervention period, you can see the slope is, this is the slope. Then after giving the intervention, you can see what has happened. The mortality has dropped significantly down, and you can see that the slope also has changed. It has become more steeper. Suppose you did not give an intervention, what would have happened? The trend would have been this. Okay, so this is called a counterfactual trend. So important thing for us to know is, did the slope change after the intervention or not? That is actually done by something called the interrupted time series. So there are two changes that we're looking for. We're looking at a drastic change in the mortality, that's called a level change. And we're looking at the change in the slope of the trend, that is called a trend change. So these are two things that we can actually do in an analysis, which this article has not done. Suppose they had done an interrupted time series analysis and they noticed that the trend has changed. You cannot still attribute this only to the strategy, because there could have been some other confounding factor. Okay, there could have been some concomitant event at the same time. So it's very important for us to also look for hidden causes. Now, what could be the potential concomitant events for this particular study? There could have been some seasonal illnesses, or the clinical protocol in all these hospitals could have changed simultaneously. For example, they had a different treatment practice. They could have had a new nursing practice concomitantly. The way they manage sepsis could have changed. Their infection control measures could also changed along with this study. And they could have also probably introduced a new hospital quality improvement initiative. Now, one thing which you can decrease these concomitant events is by actually using the sequential nature of enrollment. Because suppose I had a concomitant event here, that will affect my pre-implementation data for the other sites also. So this sequential nature of enrollment has an advantage in that way. And the authors also have tried to adjust for seasons. Now, because we did a multi-component study, how do you know which part of the intervention actually caused the benefit? Was it the AI prediction, the model which worked? Or was it the fact that they had an automated RRT notification? Or was it the fact that the electronic health record had a banner alert? Or were the clinicians overall aware of the deterioration? Or was it because of the staff education, or was it because of a combination? So they tried to find out if any one of these had a effect. So they did something called the EDI 55 to 59 versus 60 to 65 threshold analysis. So what they're saying was, whether your EDI score was 59 or 61, technically the patient should have the same risk of mortality. So if you divide those patients into two groups, patients who had an EDI score from 55 to 59, patients who had an EDI score of 60 to 65, only this group got an RRT push alert. This group did not get an RRT push alert. You must calculate the mortality. If the mortality was lower in this group, that means your RRT push actually worked. And another sensitivity analysis that they have done is, they've looked at the mortality for the green patients and also for the yellow patients to see if there was any significant benefit in these two groups also. And they've also done one more analysis called a bind analysis, where they have split the scores from 60 to 69, 70 to 79, 80 to 89, and more than 90, and they've checked the benefit. Now I just want to explain this, line that they had said, hospital clustering, random intercept was used. Now these are just 4 pictures of linear regressions. So in this linear regression, if you look at, suppose, I'll just try to explain this graph. So in the first is just a simple linear regression. Okay, so suppose you take y is your okay, for example, you take y is going to be a mortality, and if you take x is the time axis, it's your time. What they're saying is all hospitals will have the same alpha intercept. So alpha is basically the value of y when your x is equal to 0. So if I had to draw a linear equation, I would write y is equal to alpha plus beta is the coefficient of the slope into x. Okay. But on the other hand, if you say each hospital is allowed to have its own baseline mortality, what you can do is for a particular hospital, I would say, let's say y is equal to y for hospital 1. I will have an alpha, plus I will also have a variation. For this, suppose the mean was here, I would have a variation from this alpha 1 to the mean alpha intercept. So I could have a variation like A1, and then the slope is going to be equal. So my coefficient is always going to be the same, and this will be my time axis. Okay? Suppose I say that all hospitals start off with the same baseline mortality, but the way they're going to change is the way they react to the intervention is going to be different. They will have different slopes. So there you can write an equation like y alpha is going to be constant, but here your coefficient is going to change. So you can have beta plus the difference in the average to that particular hospital data's beta into x. Okay, then the last regression would be everything is different. So you'll have y1 would be alpha plus the change for that alpha for the hospital 1, plus even the way the hospital reacts is changing, the slope also changes. So you'll have beta plus beta 1 into x. Now what you must understand here is they have not at all taken time into their primary analysis. So we don't even look at the x at all. So all these, this is not taken into account because they have not looked at the time change in the regression. So if you look at what this study has done, this model seems to be the closest to what they have done, where they have taken each of the hospitals' alpha as different, and they have not looked at the slope, they have only looked at the alpha part and not the beta coefficient. So going on to the questions, was there loss to follow-up after baseline 20% or less? So there was no loss to follow-up, they have not mentioned it. And did the statistical methods examine changes in the outcome measures from before to after the intervention? So they have done, they've done a multivariable regression model and they provided the p-values. The next important question is, were outcome measures of interest taken multiple times before the intervention and multiple times after the intervention? That is, did they use an interrupted time series? Like what I mentioned, they have not statistically done an interrupted time series design, but however, they have visually provided the data. So now let's move on to the results of the study. So this is the pre-intervention group, and that next is the post-intervention group. If you look at the deaths in the pre-intervention group, you have 23.1% deaths in the pre-intervention group and only 18.6% in the post-intervention group. Now if you look at all the different types of hospitals, the academic medical center hospitals A and B, community teaching hospitals were from C to H, and non-teaching community hospitals were I and K. One thing which I noticed was, if you look at the post-intervention, the academic medical centers had more patients in the post-intervention group and less patients in the pre-intervention group. That means the academic medical centers were enrolled earlier, as opposed to the community teaching and non-teaching community, which contributed more towards the pre-intervention data rather than the post-intervention data. That means these groups would have been recruited towards the end of the study. Otherwise, race and ethnicity had no differences in the pre as well as the post-intervention groups. Now, if you look at the characteristics, one more thing which I noticed was, in the pre-intervention group, more patients were enrolled during the winter and the fall, and in the post-intervention group, more patients were enrolled during the spring and summer. So I don't know if this could have actually altered the data, because some diseases like influenza would be more in the winter seasons. Otherwise, the comorbidity score was equal in both the groups. The EDI score was also was the same in both the groups. Now, if you look at the other thing, the push notification was around 46.6 in the post-intervention group, but only 37.5 of them actually had a rapid response team. So the reasons I had already told you, that's because one of the sites did not have a night duty coverage, and some of them did not have a unified communication groups. Now, this is just to show you that what was the median daily push notification in the post-intervention period. So in the academic medical center A, per day they would have at least 10 RRT alerts. In the non-teaching community, they would have 1 or 2 RRT alerts. The other thing I wanted to show was, if you look at the rapid response encounters, like look at hospital A, pre-intervention they had 25.6 encounters. After the post-intervention, they had about 46.1% hospital rapid response team encounters. But if you look at the hospital I, you can see that in hospital I, the pre-intervention is only 16.7, but the post-intervention is only 10.9. That means this hospital has been recruited very much towards the end of the study. So one critique I had in this paper is, they did not indicate the hospitals, the order of the recruitment. They did not even tell us when the hospitals are recruited for each of the intervention. So if you had known the exact rollout sequence and date, we can actually see whether early implementing hospitals differed from late implementing hospitals. Now, coming to our main result, which I had already said, if you look at the in-hospital deaths, it reduced from 23.14 to 18.63. The absolute difference was minus 4.51. the adjusted odds ratio was 0.82 and it was statistically significant. It was from 0.74 to 0.91 was the confidence interval. These are just images from the supplementary to just show you that in each of the academic centers, the mortality has reduced. It was significantly reduced in academic medical centers as well as community teaching hospitals. But in the non-teaching community hospital, although there was the trend was beneficial, it was not statistically significant. So this is they have descriptively looked at the time trends. So if you look at the pre-intervention time trend, you can see that the slope is sort of going up, and after the intervention, you can see that the slope, overall the mortality seems to be coming down. So this is the visual depiction of the data, but they have not done it, they're not done a statistical method to actually account for this.
So how many, important thing, how many data points do they have before and how many data points after?
So for each hospital, at the time of intervention, it was anchored at 0.
But average
Yes.
numbers, actually more than almost 7, 8 before and 7, 8 after.
It seems to be 4 months before and 4 months after.
No, the number of data points before and after.
Yeah.
Quite a large number before and after. That's very important.
Okay. Next one is a multivariable regression model. So the post-intervention definitely had a lower odds of mortality. Other things which had a higher odds were being an Asian and a Pacific Islander, being of another ethnicity group, as opposed to being a white, black, or an Hispanic. When you had an EDI score, higher EDI scores had a higher mortality. Higher comorbidity scores also had a higher mortality. Now, you remember I had told about the sensitivity analysis, where they want to look at the incremental effect of an RRT push notification. So in that analysis, what they found out was, although the mortality itself dropped in both the arms, from 55, in the EDI group from 55 to 59, the mortality dropped from 2.9 to 2.3. And then in the 60 to 64 group, the mortality dropped more, from 5.5% to 3.8%. However, when you do the adjusted odds, there was no major difference. The other sensitivity analysis, what they have done is, they've looked at the mortality for red, which we saw, odds ratio was 0.82. But also important to note that the mortality of the yellow alerts also dropped. The adjusted odds ratio was 0.77. And for green, the model didn't converge because they didn't have enough events. So if you want to look at it negatively, you can say whether the patient had an RRT alert or not, anyway the mortality was improving. But if you want to look at it positively, you can say that even though yellow did not have a push notification, but just because of the fact that the electronic health record popped up saying it's yellow, clinicians would have been more aware of the patient's risk and they would have acted proactively. The final analysis they've done is the BIND sensitivity analysis. So here they found out that if your score was 60 to 69 or 70 to 79, you had an improvement in your odds of mortality. That is, even we have noticed, no, when patients when the illness severity score is higher, it's more difficult to rescue these patients. So if you look at overall, I would say that this intervention, this multi-component intervention has a promising benefit. We are seeing that the unadjusted mortality dropped from 23.1% to 18.6%. However, the adjusted odds ratio was 0.82. Some few things to consider before taking this data is, number one is intention to treat. Okay, some centers did not have RRT 24/7 or communication. Suppose all the hospitals that followed the protocol, maybe the mortality would have dropped further. But because they have not taken time into the primary analysis and the concomitant event, maybe the mortality is not as good as what they're actually showing. So coming to the last part, is this intervention feasible in our setting? So first of all, we do not have an electronic nursing health record, at least in the medicine wards, though we have it in geriatric wards. We don't have a dedicated rapid response team. If you look at our on-call team, we're actually catering to a lot of clerical and logistic issues along with the patient deterioration. And we don't have a formal warning system that is being currently used during nursing handovers. So if you wanted to adopt this into our CMC setting, the first step would actually be to establish an RRT foundation. You would need to have at least, I think, 2 teams constituting a consultant, a registrar, and a nurse who work in 12-hour shifts. And they should respond within 15 minutes for these alerts. They should make a bedside assessment and they must make an intervention, decide whether the patient needs to go to ICU, HDU, or continue in ward, and discuss the goals of care with the patient. And most importantly, we must train these teams. The second thing is, it's important for us to implement an online nursing health record for every patient. And once that's done, we can actually develop an online alert system with our CHIPS department. at least we can adopt the new score. So new score has got very simple vital parameters. We have only respiratory rate, saturation, systolic blood pressure, pulse, consciousness. This and all can be easily incorporated into a system. Once this is working, we can actually think of upgrading to an AI model. Currently, if you look at all the epics, we don't really know how well it is done in our system. So you'll have to validate the model first here. Or if we're developing a local model, we can put our own parameters which seem to work. And the other thing is to integrate this alert into the workstation. If you look at our current IP bill alerts, we already have a color coding system, right? We have patients who have a pending bill, we color code them. Likewise, we can easily adopt that into our IP list itself. Patients who are more sick can have a red alert. Patients who are less sick can have a yellow alert. And like how we have for our ED team, right? When someone's referred to a particular unit from the emergency department, we click on this flash button, and we come up to this page where all the patients' names pops up. The reason for the referral pops up. Instead, we can actually have a column for all the patients who have a high EDI. And once we have sorted out the patient, we can mark the patient as complete. That would really help. And the last thing is to actually develop a communication system. Either we had to create WhatsApp groups for RRT systems or have a separate bleep. So the last issue I want to touch upon before I close was the ethical aspect. So if you look at the ethics of the study, they have mentioned one line. The study was approved by the Rutgers University Institutional Review Board. They have not mentioned about informed consent. Do you think the study needs an informed consent? Because they have taken patient data. Okay, so just in time to answer this question, an article has come 4 days back. It's called Randomized Quality Improvement Trials, an Overview and Proposed Framework for Ethical Oversight. So if you look at what quality improvement trials are, they're a systematic effort to improve the healthcare for the purpose of improving outcomes for patients. And it's very important that these quality improvement strategies should be effective. Otherwise, you'll end up wasting resources, you'll contribute to clinician burnout, and can actually paradoxically worsen the healthcare quality. Now, this is not the same as efficacy trials, okay? Our study, though this is the ideal setting, our study did only a pre and a post intervention. So if you look at where our study falls, our study is actually a research involving human participants, okay? And our study is also quality improvement because we're looking at the improvement in hospital mortality. But is our study randomized? No. So actually our study will fall somewhere in the unshaded part of the intersection. But ideally you should do a randomized trial. Now just last slide, I will just tell you the differences between an experimental treatment trial, a comparative effectiveness trial, and a quality improvement trial. Now the primary goal of an experimental trial is to see whether your experiment works or not. Comparative effectiveness trial is to see 2 different standards of care and see which one works. Your quality improvement trial is to improve the adherence to a standard of care. So the primary outcome in an experimental as well as a comparative effectiveness trial is your health outcome. But in a quality improvement trial, you're actually looking at the quality indicator. Now, if you look at the healthcare intervention, you always mask it during an experimental or whenever you do a healthcare trial. But for a quality improvement trial, you can never mask the intervention. And the participation in trial, like if I know I'm participating in a experimental trial, all the participants must know that they're part of a trial. But on the other hand, you cannot do that for a quality improvement trial, because what will happen, you'll have something called the Hawthorne effect, which is called, if someone knows that they're being observed, they'll immediately perform better. Okay, so the risk from a quality improvement trial is very minimal because you're always giving standard of care. You're only comparing, is there anything better to improve the adherence? That is why you don't need informed consent for quality improvement trials, but you have to have informed consent for all your experimental trials. That is why for all quality improvement trials, which I think our study will fall under, you can waive off the informed consent because number one, it's impractical, it's not practicable. Next thing, it has minimal risk to the patients. And third thing is nobody's right and welfare is compromised because of this intervention. So what I think they should have mentioned was, for a retrospective quasi-experimental trial study using existing EHR data, individual consent might have been waived by the IRB. So they should have mentioned the fact that the informed consent was waived by the IRB. So the learning points which I learned from during preparing for this session was, I learned about the 7 intervention categories. And we covered various designs available for implementing strategies, that is within site designs, between site designs, within and between site designs. And we also saw the problems with simple pre and post implementation design. That is, we're not taking into account the secular time trends. There could also be confounding and concomitant events. And third thing is, a good way to actually address the secular time trends would be to do an interrupted time series, which they do not address in this article. And just an overview of the quality improvement trials. So these are my references. Thank you for your listening.